So on the left-hand side was the heart.org. I don't know if any of you read John Mandrola's Musings, but he had this whole section about how FFR had failed twice in 2021, the FAME3 trial and also the Flower MI trial. And then on the right-hand side, a headline from TCTMD saying how negative trials spur debate over the role of fractional flow reserve. And so what I wanted to do was to talk about two of these trials. And I want to start off by talking about FAME3. And then because I already talked about Flower MI in the earlier talk about acute coronary syndromes, instead I'm going to talk about Ripcord 2, which is also a fascinating study. And in order to talk about FAME3, what we really need to think about as well is what was being learned about PCI versus CABG while FAME3 was going on. Because while they were doing that trial, others were taking and pooling the individual patient data from a large number of randomized trials, and it led to several really important messages that were not known at the time that FAME3 was launched. As you can see here, when you pool 11,000 patients randomized to CABG or PCI, people live longer with bypass surgery. I wish it weren't so. I'm a PCI person, but it's true. You will live longer if you have bypass surgery instead of stenting. Now, it doesn't happen right away, so you can see that for the first year, they look the same. It's only after the first year that the mortality benefit becomes apparent. Interestingly enough, this benefit is driven by the diabetics. You can see on the left-hand side, the curves separate for diabetes. On the right-hand side, they do not separate if you don't have diabetes. Similarly, if you look on the left-hand side, it's not the left mains that show the mortality difference. That's not where the benefit is. The benefit is on the right-hand side for patients who have multivessel disease. So it's your diabetic who has multivessel disease who is the clear winner for bypass surgery in terms of mortality instead of PCI. No doubt about it, 11,000 patients, just can't argue with that. What about strokes? Clearly higher with bypass surgery, but only higher during the perioperative phase, right? You can see the time scale there. For the first month, higher with CABG. For the next 5 years, no significant difference. It's only peri-procedural stroke. However, it's interesting to ask who gets those strokes. It's the same people who have the largest mortality benefit. So it's the diabetics and it's the multivessel disease who have the higher stroke risk, but they're the very ones who live longer when you do bypass surgery instead of PCI. Now, there are other endpoints other than stroke and mortality. What about myocardial infarction or repeat revascularization? Here, CABG wins also. Look on the left-hand side. Again, this is a meta-analysis that just came out in December. This was focusing on left main disease, and you can see that spontaneous MI lower with CABG than PCI, and on the right-hand side, fewer repeat revascularization. So if I could, and again, I'm a PCI person, just like you. I wish it weren't true. PCI is great, but CABG is better. It's better because there's a lower mortality rate. It's lower because patients have fewer heart attacks and they need fewer repeat procedures. There is a stroke risk, but the stroke risk is in the very people who benefit the most for mortality. All right, so that is what they learned while people were doing FAME3. So here's what FAME3 was. A trial where patients couldn't have left main disease. So basically, it was the multivessel disease population who were felt to be candidates for either PCI or CABG at a heart team discussion. Randomized, you had to have an LAD that was important, so you had to be getting a LEMA, and then you came in and you either got FFR-guided PCI or bypass surgery. Here's the upshot. FFR-guided PCI was not non-inferior. That's like one of those horrible statements, right? It's like saying something is not unlike or something like that. Like, do the two things cancel out? I don't know. You can see that the 95% interval, confidence interval goes from 1.1 to 2.2. The reason they didn't say it was inferior, even though the confidence interval is greater than 1, is because of multiple testing. But you wonder what's going to happen with the 3-year follow-up, right? It sure looks like FFR-guided PCI is going to end up being inferior if we follow this cohort for long enough. Now, again, this was the all-cause death, MI, stroke, and repeat revascularizations. How different was this than the pooled cohort data I just showed you? Not very different at all. Now, it's smaller, but look at all of these clinical characteristics. Very similar, maybe fewer diabetics, that's true, and obviously FAME3 by design had no left mains. But if you look at procedural characteristics, syntax severities, number of grafts, number of stents, FAME3 enrolled essentially the same cohort that we have looked at and found cabbage to be better in. I'll take a very brief, quick, deep dive into these various endpoints. Again, very small numbers. As you'll see, 19 deaths. Generally, FFR-guided PCI was greater than cabbage. The event rate overall was lower. If you look at myocardial infarctions, again, just 42 infarcts in the group, so hard to say too much about it. But again, FFR-guided PCI was worse than bypass surgery. And if you look at redo PCI cabbage, again, only 75 or so during the follow-up period. But again, FFR-guided PCI was worse than bypass. So every single endpoint goes as expected. Stroke, only 15 strokes, and they were actually completely balanced between the two groups. Some people have said, well, maybe it's a syntax segment issue, right? Maybe if we just take the low syntax segment people, they're the ones who will actually derive some benefit. And this is one of the figures that was in the FAME3 paper, suggesting that the low syntax cohort perhaps would fare better with PCI. But again, when you look at these very, very large trials, like where they pooled all 11,000 people together, syntax segment does not matter. For multi-vessel disease, you always live longer with bypass surgery than PCI, even in the 0 to 22 segment, right? The fact that there is not a significant p-value for interaction means that cabbage always wins. What about FFR in FAME3? It was measured in about 80% of lesions, because again, 20% were CTOs, so they couldn't measure it in those ones. When they did measure it, the FFR values in this trial were quite low, 0.7, right? And in the lower bottom left, I show you how that compares to the other FAME trials, 0.71 for FAME1, 0.68 for FAME2. So these are quite severe lesions. After PCI, it went up to 8.8, so that's quite a big difference, right? 0.70 to 0.88. And interestingly enough, 3 out of every 4 FFRs was positive. That is, very few vessels ended up being FFR negative in this trial. And I suspect we'll see a future sub-study telling us exactly how many. So if I could answer this question, did FFR fail in FAME3, I would say 2 things. First, it simply told me what we had already learned while the trial was going on, that in severe multivessel CAD, cabbage is a better therapy than PCI. Wish it weren't so, but that's what the data shows us. And second, if you do a test and the test is always positive, you don't need to do the test, right? If you take a cohort where 3 out of every 4 FFRs is positive, you're not converting many vessels over to medical therapy. All right, ripcord 2. So when we use a test, it's important to understand how it fits into our diagnostic pathway to therapy. So some tests are replacements, right, because they're cheaper or less invasive. Some are triage tests like D-dimer for pulmonary embolism, where if it's negative, you do one thing, but if it's positive, you need to triage them to something else. FFR, though, is what's called an add-on test, right? If you look at the way it was used in the trials, you can see the quote there. These vessels were thought to require stenting on the basis of clinical and angiographic data. FFR augmented clinical judgments, not a replacement. FFR was used what I would call selectively. But what happens if you use FFR systematically or routinely? So one way of thinking about this is to make your decision on how you're going to treat before you know the FFR value, and then to measure FFR and see if you change your mind. And there's been many trials that have looked at this. I quote them down on the bottom here, but basically 60% of the time we make the same decision. So that's good. Most of the time we get the same answer no matter what. Trials like FAME have really looked at what you call downgrading, taking PCI, FFR is negative, converting it to medical therapy, right? That's downgrading things. We know that works. But what about the opposite? What about a vessel where you say, hey, I'm going to treat that medically. You measure the FFR, it's 7.8. Maybe I should stent it. Maybe I should bypass it, right? That's what we call upgrading. You said you were going to do medical therapy, but then you made an FFR measurement and it led you to do something else. That had never been tested before. And in some ways, Ripcord was a trial of using systematic FFR. Every single vessel that had a 30% diameter stenosis and was at least 225 got FFR measurements. So they made a lot of FFR measurements. And what did they find? They found, and again, this was a trial done in the United Kingdom, so they were very focused on resource utilization, right? They found that there was no cost difference between these two trials. And if you look at quality of life scores, patients didn't feel any better using one strategy or the other. Why did this happen? The reason is that the ultimate treatments didn't really differ between the two strategies, and I want to highlight what happened in this trial. Medical therapy was about 30% in each group. That didn't change too much. What happened when you added FFR is actually the PCI rents went down, which you'd expect, but instead of medical therapy going up, bypass surgery went up, right? 9% up to 12%. So you converted a bunch of PCIs to cabbage, and as a result, clinical outcomes at the bottom, no different. And I don't know the answer, but I want to put forward this theory. I wonder if selective FFR avoids finding these borderline gray zone FFRs in the LAD. If you look at how often we stent the LAD in very large pool trials, this was one that came out at Lancet, the pool like 26,000 patients or something, we stent the LAD about half of the time. Half of all of our stents go in the LAD. And that makes sense because the LAD supplies about half of the muscle in the heart, right? But when you look at some of these FFR trials, and I was a PI for some of the ones down there at the bottom, we're doing like 70% LADs in these ones. Why is that? One reason certainly is that there's more flow down the LAD because there's more mass, and sort of the same perfusion, you'll get more flow, and so a larger pressure gradient. Look at this study from Germany, 59 marathon runners, all asymptomatic. A third of them had positive FFR CTs in the LAD, right? There are these lower FFRs in the LAD that don't need to be found. There's also a small hydrostatic effect in the LAD as well because it courses above the level of the left main, and that leads to a small hydrostatic effect. So what about ripcord 2? Did it fail? Did FFR fail? What it has taught me is, number one, we shouldn't be systematic about FFRs. We need to be selective. We still need to be doctors. We need to take all of the data and put it together before we make an FFR measurement. And I worry that we're getting too distracted by making FFR measurements in the LAD, and they send a bunch of patients to cabbage that didn't need it. Thank you.